Okay. Imagine this. You're up in the mountains. There are mosquitoes like everywhere, real bad, and instead of, I don't know, swatting them away, you pull out your phone to make an announcement to the world.
But not just any announcement. About 6 months ago, a highly successful MIT-educated, Duke-trained neurosurgeon stood there, on camera, with swarms of mosquitoes attacking him and,
Like literal swarms.
yes, literal swarms, and he announced that he was quitting medicine.
Wait, quitting? Just like that?
Just like that, and you know what? That video exploded. 15 million views, David. It became this huge online moment.
Okay, I gotta ask. Why do you think people watched it? Like, yeah, okay, mosquitoes, drama, but why would that go viral?
Well, it wasn't just the spectacle. It was what Dr. Gooby, I know, unusual name, what he said in that video really hit a nerve. He didn't just quit his job, David. He called out the entire healthcare system.
Oh, wow. Just like straight up?
Exactly. He explained that the reason he was leaving wasn't only burnout, though he certainly struggled personally and emotionally. It was because he believed that our healthcare system wasn't designed to actually make people more healthy. Now he's focused on mental well-being, enjoying nature, and a healthy diet.
Ouch. That's pretty harsh. But honestly, I mean, is he wrong?
That's exactly why it resonated. It wasn't just some random critique. This is a neurosurgeon, someone who reached the very top of his field. And here he was, walking away, saying the system we trust with our lives is fundamentally broken.
Okay, so this isn't just one guy being dramatic. This is like systemic, huh?
Completely systemic. And his story, well, it highlights the cracks in a way that's hard to ignore.
You know, Sophia, what Dr. Gooby said, it's hard to shake, right? I mean, when someone like him, with all his credentials and experience, just walks away like that, it really forces you to confront how deep these systemic cracks go.
Exactly. And the truth is, David, his story isn't isolated. For every Dr. Gooby, there are thousands of healthcare professionals, nurses, doctors, paramedics, facing similar frustrations. The system as it stands is driving many of them to the edge.
And it's not just healthcare workers, right? I mean, regular folks like us, we feel it too. Trying to navigate insurance, costs, wait times. It's enough to make your head spin.
Absolutely. Which is exactly why we're taking a closer look today, to discuss what's really driving our health system. Spoiler alert, it's not the things that should be driving it.
Wait, there's a should? Like, there's an ideal version of this somewhere?
Oh, definitely. And we've talked about it before, remember? In the first couple of episodes, we outlined some crucial ideas that should shape every part of healthcare, from policies to research to how we even think about health itself.
Okay, yeah, I remember. But maybe give us a quick recap. You know, for listeners who might have jumped in late.
Of course. So first, we talked about having a relentless shared vision of health for all, where everyone, regardless of their background, has access to what they need to live the healthiest life at the lowest cost to society.
I love that idea. It sounds so, what's the word, aspirational. But also, how realistic is it?
Well, that's the challenge, isn't it? But it's not impossible. The second concept we discussed is key to making it work. Shifting from a rigid linear mindset to what we call a complex adaptive systems paradigm.
Complex adaptive systems, huh? Sounds complicated. But I guess it means the system has to, like, adapt to what people actually need instead of giving the same one-size-fits-all solutions?
Exactly. And that requires more than just technical changes. It needs leadership, or as we've called them, system stewards, who understand and advocate for this perspective.
Okay, cool. So that's two. What's the third again?
The third was the idea of connection and mobilizing people to act for change, targeting those high-leverage points where small shifts can lead to big systemic impacts.
That definitely sounds like a tall order, but also kinda exciting? Like real change could happen.
It can, David, and it has before, but before we get into that,
All right, Sophia. Before we dive deeper into those ideas, I know you're always digging up the most fascinating insights. What's caught your attention this week?
oh well, I'm almost done reading something pretty remarkable, The Doctors Blackwell. It's this biography about the Blackwell sisters, Elizabeth and Emily, who were the first women to become formally trained physicians in the United States. It's such a poignant reminder of how what seems impossible at the time, like women breaking into medicine, can actually change the world.
The first trained female doctors? That must have been, what, late 1800s?
Exactly right. Elizabeth Blackwell earned her degree in 1849, which feels like a lifetime ago, but you start realizing history has this way of echoing back.
Okay, but tell me, what's the hook? Like, what keeps you turning the pages on something that's, what, nearly 200 years old?
The hook is how much their struggle still resonates today. They faced incredible resistance but pushed forward because they believed women belonged in medicine. And ironically, you see parallels in modern healthcare, what it takes to challenge entrenched systems.
Wow. Challenging systems seems to be the theme of the show. Okay, but let's step away from old-timey biographies for a second. Podcasts. What do you have for podcasts?
Oh, I've got a great one for you. It's an episode from Dr. Zach Cohane on the New England Journal of Medicine AI Grand Rounds podcast. And all I'm going to say is, David, AI is here to stay.
Wait. AI? Like artificial intelligence? In healthcare?
Absolutely. He dives deep into how AI is fundamentally changing medicine right now, not someday, not in the distant future, but here and now. Dr. Swanson says the same. It's a total game changer.
Okay, I've got to listen to that. But before I interrupt again, what else is on your list?
There's also an episode from Dr. Robert Pearl's Fixing Healthcare. They talk about how our winter viruses, vaccine skepticism, and of course the broken healthcare system are all colliding in America right now. It's a perfect storm.
Sounds like a lot. But honestly, also super relevant, like shockingly so.
Relevance is definitely the key. It makes you wonder what kind of conversation we could be having if we all took a step back from the noise and actually talked about the real incentives, about why people do what they do every day in our health system.
You know, Sophia, what you just said about understanding the real forces in our health system, it's really sticking with me. I mean, these foundational drivers you mentioned, are they the ones we should even have? Like, how did the system get shaped this way in the first place?
Well, it's a great question, David, because when you really think about it, what should drive a healthcare system? You'd hope it would be, the health of people, making sure everyone has what they need to stay well and at the lowest cost possible. But that's not our reality right now.
Okay, but if it's not health, then what? Like, what's at the wheel pulling all the strings?
The healthcare system as it stands is being driven by what I'd call the wrong incentives: short-termism, individualism, profits, and elitism. These aren't just random buzzwords. They're deeply baked into how the system works. And they didn't show up overnight.
Wait, what do you mean? They didn't show up overnight?
I mean, these drivers have historical roots. They trace back to how modern medicine evolved, especially in the late 19th and early 20th centuries. We inherited these values, David, and now we're stuck with them unless we consciously push to change them.
Okay, wait, let's break this down. Short-termism. That's like focusing on immediate results instead of long-term solutions, right?
Exactly. It's about what looks good now, on paper, in quarterly reports, but often at the expense of long-term health outcomes or sustainability.
And individualism? What's that about in healthcare? Like people wanting to just do their own thing?
Pretty close. It's this idea that instead of seeing health as a shared collective responsibility, we treat it as an individual burden. You get sick? That's your problem. Can't afford care? Figure it out yourself. And it's all, tied into this myth of, pulling yourself up by the bootstraps.
Yeah, but health doesn't work that way, right? I mean, if someone in your community is sick, doesn't that, affect others? Isn't it kind of connected?
It is, completely. And that's what makes individualism potentially so damaging. It ignores the interconnectedness of health. But let's not stop there. Let's talk about profits.
Ah, profits. Here we go. Okay, let me guess. Money over morals?
That's one way to put it. Profit motives aren't inherently bad, but when they take precedence over health outcomes, people suffer. You see it everywhere, from pricing life-saving medications astronomically high to prioritizing lucrative procedures over basic preventive care.
So basically, the system's making bank by keeping people less healthy longer than it has to?
That's brutally put, but yes. And then there's elitism. It's this underlying belief that certain people, because of their wealth, education, or status, are better or more deserving.
And those barriers are everywhere, like those insurance approvals that take forever, or hospitals that won't even take you unless you can front the money.
Exactly. And the thing is, these aren't fringe issues. They're systemic. They're built into how the machinery of the health system runs. And unless we recognize these drivers and work to shift them, we'll keep perpetuating the same inequities, the same inefficiencies.
So, Let's start unpacking this short-termism you mentioned earlier. I mean, it really does feel like one of those concepts you hear a lot about. But what does it actually mean in real life for how healthcare is run?
It's a great question, David. Short-termism in health means focusing on immediate outcomes, things like quarterly cost savings, or short-term metrics, or episodes of treatment, or academic publications or public health projects. It's everywhere, really, at the expense of long-term health investments. And here's the irony. Those long-term investments actually save money and improve outcomes over time.
Wait. So we're talking stuff like preventative care, right? Like stopping problems before they even start? But doctors aren't paid to make people more healthy. They're paid to see more patients, right? Fee for service?
Exactly. Preventative care, public health infrastructure, addressing social determinants of health, all of these are seriously underfunded. For example, the U.S. spends only about 3% of its healthcare budget on public health measures. But it's not just funding, it's also non-financial influences like our collective vision. That's all despite knowing that interventions like childhood immunizations or smoking cessation programs can return up to $10 for every $1 spent.
10 to 1? That's like a no-brainer. Why wouldn't everyone jump at that?
Because the benefits aren't immediate. The return might not show for years, sometimes decades. And right now, our system is wired to look for quick wins, things that show up on the next balance sheet or performance report.
But it's not just the government or hospitals or organizations. Personally, I have a hard time sticking to a healthy diet or my exercise plan. Seems like short-term thinking is built into being human. Okay, but then, what happens when we ignore the long game? Like, what are we missing out on?
We miss out on healthier populations and more equitable outcomes. Take chronic diseases, for example. They account for about 90% of U.S. healthcare costs, yet most of the system's response is reactive. Instead of proactively addressing the root causes through community programs, we wait until problems escalate, when they're harder and more expensive to treat. Then people end up in the ERs and ICUs, or worse, they don't.
Yeah, but isn't that exactly why marginalized communities suffer more? Because the system ignores those broader issues that cause poor health in the first place?
Yes, David. Marginalized groups are disproportionately affected by things like poverty, housing insecurity, even environmental hazards. These are systemic issues deeply tied to health outcomes. But when we focus solely on short-term fixes, we end up widening the gap rather than closing it.
Okay, so it's not just bad for health, it's bad for fairness too. You solve one problem, but 3 new ones pop up down the line.
Exactly. And research backs this up. Think of the work by Sir Michael Marmot. It shows how addressing upstream solutions, like targeting inequality and improving living conditions, leads to better health for everyone. Ignoring these root causes, well, it just perpetuates inefficiency and inequity.
Wow. And yet, 3%, right? That's all we spend on prevention?
3%. It's staggering when you think about it. Public health should be the foundation of healthcare, yet it's treated more like an afterthought.
So, what's the fix? Like, how do you rewire a system that's so stuck on chasing quick wins?
It starts with shifting our mindset. We have to recognize and, more importantly, prioritize long-term benefits over short-term rewards. But that requires systemic change, David. And as we know, systemic change is never easy.
No kidding. But, I guess we're not quite done peeling these layers back yet. Okay, Sophia. So you were saying how focusing on the system's flaws misses the bigger picture. It's got me thinking about that individualism idea you brought up earlier. Are we really blaming people for their own health instead of looking at the system they live in?
Exactly, David. It's the idea that if someone's unhealthy, it must be because they're not eating right, not exercising, or, making bad choices. And while those behaviors play a role, they're just a small piece of a much larger puzzle, almost certainly less than 50%, and probably much, much less.
Okay, but, don't we have to take some responsibility? I mean, no one's forcing me to eat a cheeseburger, right?
Of course, personal choices matter, but they're deeply influenced by the conditions around us. For instance, if you live in a neighborhood without access to affordable, fresh food, it's much harder to eat healthy, even if you want to. Or if you're working 2 jobs just to make ends meet, when do you have time to exercise?
Oh, right. Like the system kind of stacks the deck against you?
Exactly. And here's the thing. Individualism treats health as though it's disconnected from those systemic issues like poverty, housing, or even education. But studies, like the ones by Michael Marmot, show that things like socioeconomic status are huge predictors of health outcomes.
Wait. So it's less about what we do and more about where we start?
Precisely. Health outcomes usually reflect the social determinants of health, the stuff we often can't control, like whether we have access to safe housing or whether our schools teach us about nutrition. But our system is, well, laser focused on individual behavior instead.
Huh. Okay. But isn't that just how people think in general? Like the whole you get what you deserve mindset?
That's exactly it. It's this deeply ingrained cultural narrative, especially in the US, that health is a direct result of personal effort. But what that ignores is how interconnected we actually are. David, have you heard of the study by Christakis and Fowler?
No, but I'm guessing you're about to blow my mind again.
I'll try. So, they found that health behaviors, like smoking or even happiness, are influenced by our social networks. And not just our friends, but our friends' friends. It's a ripple effect.
Wait, hold up. You're saying my health could be tied to someone 3 degrees removed from me? Like someone I don't even know?
Exactly. And that's the problem with individualism. It completely ignores these connections. Health isn't just about the individual, it's about the environments and communities we're part of.
So we're all, way more linked than we think. But the system's out here treating us like we're all on our own islands?
Yes. And it's not just neglectful, it's harmful. It shifts responsibility onto people for outcomes they often can't completely control, while ignoring the broader factors that actually drive health.
Wow. Okay, so it's like we've been blaming the players when the game itself is rigged?
Exactly. And if we want a health system that actually works, we have to stop focusing primarily on the individual and start addressing those upstream systemic issues that affect everyone.
All right, Sophia. So if we're talking systems and how they shape health, I've got to ask, how did we end up with a system that seems more about profits than people? I mean, healthcare is supposed to be about saving lives, not saving spreadsheets.
Great way to put it, David. The truth is, in the US, healthcare isn't treated as a basic human right or even as a social good. It's too often treated as a market commodity. And that means profits, what makes money, become a major driving force.
Okay, so how bad are we talking? Give me the bottom line here.
Well, the US spends about 18% of its GDP on healthcare. That's more than any other country, by a long shot. And yet we have some of the worst health outcomes, lower life expectancy, higher infant mortality rates, compared to nations with universal, non-profit healthcare systems.
Wait. So we're spending more to be worse off? That can't, add up at all.
It doesn't. And the thing is that money isn't going toward better care or population health. It's being siphoned off to fuel the profits of big players, pharmaceutical companies, private insurance, even for-profit hospital systems.
All right, let me guess. Big Pharma at the top of that list?
Bingo. A prime example is insulin. In the US, insulin prices have been, and in some instances still are, 10 times higher than in comparable nations. It's a life-saving medication that's been around for decades, yet we allow companies to jack up prices under the guise of innovation or market freedom.
10 times?
10 times. And the result? Too many diabetic patients struggle to afford it. Some end up rationing their doses, which is dangerous, even life-threatening. It's an indictment of how profits often take precedence over people.
Okay, hold on. I get businesses want to make money. Fine, that's capitalism. But at what point does it just become exploitation?
That's exactly the issue. And it's not just insulin. You see it in how hospitals prioritize lucrative procedures, like elective surgeries or advanced imaging, over basic preventive care. These are profit centers, David. Preventive care, on the other hand, doesn't bring in the same revenue, so it gets sidelined.
So basically the system's set up to treat sick people, not keep them healthy in the first place. It's like a fire department that only works if there's a blaze big enough to bill for, and they get paid even if the fire keeps getting bigger.
Exactly. And the irony, David, is that prevention saves money in the long run. But when the system is focused on profit-driven priorities, long-term benefits get overlooked.
Yeah, it's like we're building a house of cards here, right? One gust of wind and the cracks start showing.
Absolutely. And the cracks are already there. The high costs, the disparities, the poor outcomes. It all goes back to this profit-first mentality that undermines health equity and efficiency.
All right, Sophia. We've been talking about this profit-first system, but it makes me wonder, does this all tie into something bigger, like elitism? How does that idea actually show up in healthcare?
Elitism is a big one, David. It's this idea that certain people, because of the color of their skin, their gender, their credentials, where they studied, or their professional titles, are automatically seen as more credible, more important. And it's deeply embedded in our healthcare system.
Okay, so you're talking like a Harvard-trained doctor walks into a room, they get the mic, but say a community health worker doesn't?
Pretty much. And it's not just about who's talking, it's about whose knowledge is valued and who gets to make decisions. For example, consider a highly educated Ivy League physician compared to a local community health worker. That health worker might not have an MD, but they're deeply embedded in the community. They understand cultural dynamics, local problems, even how people access care day to day. Yet they're systematically overlooked because they don't have the elite credentials our system prioritizes.
But wait, do we have any proof those health workers actually make a difference? Or is this just like us saying, hey, they're underappreciated?
Oh, we have proof. Absolutely. Studies show that community health workers, or CHWs, significantly improve health outcomes, especially in underserved areas. They help reduce disparities, connect people to resources, and provide preventive care in ways that formal systems often can't. But despite their impact, CHWs are often poorly funded, poorly supported.
So they're literally doing more with less?
Exactly. And it's all because we've built a system that devalues local expertise. Instead of asking, what actually works for this community, the question becomes, who has the most impressive credentials? And that prioritization perpetuates inequities.
Okay, so the system just decides academic pedigree and fancy titles win the day. But isn't some of that valid? Like, don't you want to trust someone who's got all the right training?
Of course, training is important. But here's the thing, David. Elitism isn't about recognizing good training, it's about excluding other types of valuable knowledge. Take a community mother who's navigated health barriers her entire life. She knows her community inside and out, what works, what doesn't. That lived experience doesn't come with a diploma, but it's just as critical in shaping effective healthcare solutions.
That sounds wild, that we'd ignore someone who actually lives the challenges we're trying to fix. It's like building a bridge without asking the people who live on either side of the river.
Exactly. And it's not just hypothetical. Look at global community health worker programs. In nations like Rwanda and Brazil, CHWs have made an incredible difference. They're integrated into healthcare systems and given real support. The U.S., meanwhile, keeps sidelining these workers.
So we're talking like a lesser effort to fund or even trust them here?
Yes. And that lack of trust ties back to this point about elitism. It's almost as if we can't recognize the value of contributions from non-traditional sources, like rural health advocates or individuals with disabilities. It keeps the healthcare system from being as effective as it could be.
Ugh, it's frustrating. It's like we have so many tools to fix the problem, but we're using only the ones that look good on a resume?
That's a good way to put it, David. And until we shift away from elitism, until we start valuing diverse voices and knowledge systems, we're going to keep hitting the same dead ends in healthcare reform. David, if you think about it, this elitism we've been talking about isn't just a small issue, it's baked into the entire system. These outdated hierarchies and misplaced priorities are steering the health system away from what it's actually supposed to achieve.
Yeah, it's like the system's on autopilot, but the settings were designed for the wrong destination.
Exactly. And the thing is, it doesn't have to be this way. Systems, by their very nature, can change. If we can shift our core values, if we start prioritizing health over profit, equity over elitism, long-term thinking over quick fixes, the transformations we'd see would be, honestly, unimaginable.
Unimaginable? That's a big word, Sophia. Like, what kind of changes are we talking here?
Revolutionary ones, David. Picture a world where the focus isn't on what the system can take from people, but what it can provide, where institutions and incentives align around making healthcare accessible, equitable, and affordable for everyone, and communities where we can all thrive. It would be a historical shift on par with, well, the invention of modern medicine itself.
Wow. Okay, so it's not just about tweaking the system. It's about completely rethinking it from the ground up?
Exactly. We'd need new stories, stories that center around collective well-being. We'd need institutions willing to hold themselves accountable to those values. And we'd need leaders who prioritize collaboration and trust over competition or status.
It's exciting, but also kind of terrifying, right? Like, how do you even start something that big?
One step at a time, David. Change happens in those small moments, those high-leverage points where decisions ripple outward. And that's why conversations like this matter, because they plant the seeds for what could come next.
All right. Well, I think you've officially given all of us something big to think about. And maybe, just maybe, some hope too.
Hope is where it all starts. And that's all we have for today. Thanks for diving into this with me, David, and thanks to everyone listening out there. The future of healthcare is in our hands.
Couldn't have said it better myself, Sophia. We'll see you next time, everyone.